Make a note of the members present. Ken Crandall, David Walls, Jerry Nielsen, Dana Seandell, and Rich Rydell by phone. Got that?
Yes, she has it.
Okay. Let me get my agenda here. We'll start with the Pledge of Allegiance. If any volunteers to lead? If not, I'll start. I pledge allegiance
to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Is that going to be our new house? That's it. Nice. Joint conference attendees, what is that about?
You were going to assign who was going to go with you to joint conference, and it's March 14th.
Oh, okay. Will you have the dates?
Well, and I was going to ask that med staff on March 14th if we can move that date just because I need to be at Sac Valley Medicare. There's a very important meeting down there on that date.
The med staff meeting?
No, at March 14th, which is right now the joint conference date.
Okay, you're going to check.
And so I was going to ask that med staff, can we move that date?
Okay. Are there any volunteers that would like to attend the joint conference?
What day of the week does it fall on?
It's
They're
usually
usually Thursdays.
It's Thursday? No, it's not good for me.
But you're changing it.
I'm going to try it, yeah, because joint conference is from 12:30 to usually 1:30, 2 o'clock, and I need to be in Chico by 3.
Sure. No, I'm just.
Well, what day of the week would be good for you?
Thursdays and Fridays are class teaching days for me, so other than that, I'm pretty good.
Okay, if we can change that to Monday or Tuesday, you'll be available? Okay. And do you want to go to some?
I beg your pardon?
Do you want to attend any of the joint conference
Well,
meetings?
we usually each take one.
Yeah. And you want to go to one? Okay. Does it matter which one?
Yeah, I didn't bring it with me, but I can send it.
So
Okay.
we'll have you attend the next one if we change the date so that it's on a date that you can attend, and then I'll get in touch with the two of you on. Rich, do you want to attend any? Are you going to be around?
Not till May.
Okay. Well, they're only every 3 months.
Right, there's June 20th right now, and then
June 20th? No, can't do it.
the September and December was out of question, so we need to find out.
Okay.
Oh, put me down for September then.
Okay.
Okay, we'll see that everybody at least gets to one. I think that's good to do that. Moving along now, the public comment period. Is there any comment from the public? Okay. There being none, I did want to make one real quick announcement. I'm sorry for the inconvenience this has caused everybody. It clearly was my fault that the scheduling mix-up happened, and I will make sure that something like that doesn't happen again. But I just want you all to know that I apologize for the inconvenience, and I appreciate everybody being here. Okay, has everybody had a chance to look at the minutes?
I have a couple of things, of course. On the Agenda 12 capital budget, the sentence, we will get a true capital budget brought to the board in advance. I don't know in advance of what.
In advance of the next fiscal year is my intent of my comment. That's quoting me.
Okay. So could we change that to in advance of the next fiscal year? Is that appropriate?
Well, I can't change what was said, but I can put it aside on it.
Okay. And on Agenda 12, anything from either one must be approved by the board. It doesn't have anything to do with how much money is being spent. Any
No,
expense.
both of the board restricted funds, it doesn't matter how much taken out, it has to be approved by you guys.
if it's $10, it has to be.
If they're board restricted, you can't touch them.
Okay. And then, agenda 15, so the committee is being dissolved. I think we're still with that committee,
I'm sorry?
ad hoc, right?
No, because we presented our findings to the board, our recommendation, and now it's up to the board to make discussions and changes. But Ken and I are not going to be meeting anymore as an ad hoc committee.
Okay,
Is that your understanding, Ken?
Okay, so it should say this committee was dissolved at the last meeting, right?
Yes.
Yeah, I did.
Anything else?
My only question was, I noticed that Dr. Wall's votes aren't recorded on here, and I wasn't sure if that was an oversight. I'd sent an email, but that was today.
No, I didn't vote.
Oh.
I didn't vote.
You didn't vote last week?
Yeah. Well, and here's the question, is do the board members want me to vote? Because if an item has already passed, I don't see any reason for me to vote. But if you want to know my opinion, I'll cast the ballot. So it's up to you guys. If you want me to vote, I will.
I would suggest that it's not only for us to kind of know what your opinion is, but it's for the community.
Okay, and then from now on, I will vote also. But I will vote last. Okay, medical staff report, Dr. Ware, yes.
Committee report.
I'm sorry, could somebody make a motion to
I also moved to
approve
minutes
the
with
minutes?
the changes noted by Dana.
Is there a second?
I'll second.
All in favor? Jerry?
Aye.
Dana?
Aye.
Rich?
Aye.
Ken?
Aye.
And I'm an aye. Okay, medical staff report, I think Dr. Ware is working the emergency room today. So, I did take a look at this, no one else here to give the report. The telehealth appointments, the Dr. Schneider's appointment, and Dr. Dempsey's been here quite a while, several years now. These are all in order. I don't know if you want to vote on them separately or all in one, but I'll need a motion one way or the other.
I move we accept medical staff appointments and reappointments and the policies revised and policies made.
Well, there might be some questions on the policies. Let's just do the appointments and reappointments first.
I amend my motion to, I move that we approve the appointments and reappointments.
Second.
All in favor? Jerry?
Aye.
Dana?
Aye.
Ken?
Aye.
Rich?
Aye.
And I'll vote aye. Under policies, my question here, Rosanna put all this together. Does this apply to all skilled nursing patients or just the ones in long-term? But the swing patients, it doesn't apply to swing patients?
Correct, the swing patients that fall under the acute policies.
Okay. And then there was also one item in there about physical therapy. Does the physical therapist come to the department to work?
No, they go to him. If they get a physical therapy work, they have to be able to go to him.
Okay. Those were the only two questions I had about it. Does anybody else have any input or questions?
Just to build on that, I'm assuming the physical therapist goes to, they have to come to,
Into the acute and the swing.
okay, they have to come to him though, because he has equipment, and I just wondering what they're kind of thinking was.
The skilled nursing patients go to him because of that. The inpatients and the swing patients, he comes to
He
them.
comes now, okay. Thank you.
But the occupational therapist can do both.
Yes.
Does that make sense?
Yep.
Any other comments? Is there a motion to approve these policies?
So moved.
Is there a second?
I'll second.
Those in favor, we'll go in the reverse. Ken?
Aye.
Dana?
Aye.
Rich?
Aye.
Jerry?
Aye.
And I'll vote aye. Okay, Steve, financial report?
We're under tab C. Okay, we're looking at and talking about the month of January 2019, the 7th month of our fiscal year. For the month of January, we did have a profit of $739,412 versus a budgeted profit of $843,417 for a negative variance of $104,000. Both the components of the profit and a component of the negative variance for the month of January was our prime grant payment. We received $600,000. We had budgeted for $750,000. The prime grant has measures that were held to, and we met all the measures but one. So we received 20% of our 20% reduction in our payment. During the month, we also received our first semi-installment of the property tax revenue, and that exceeded budget by $30,000. For the year-to-date, there was a loss. For the year-to-date, we now have a loss of just under $418,000 versus a budget of just under $138,000. Revenue for the month ended at $2.48 million compared to a budget amount of $2.24 million for a positive variance of approximately $236,000. Net patient revenue as a percent of gross is 51.3 compared to budget of 52.0, which is a slight negative variance and was due almost entirely to a variance in bad debt expense. We had 33 acute inpatient days in the month versus a budget of 34, and 45 swing bed days versus a budget of 17, resulting in an average daily census of 2.52. The skilled nursing unit had an average daily census of just under 15.9 with 16 beds available. That's occupancy percent of 99.4. Outpatient volumes, the outpatient had a positive variance, but the volumes were both up and down. Emergency department, physical therapy, and radiology were up, and to a lesser extent down, whereas lab, pharmacy, and surgery. Lake Almanor clinic visits were down due to a decrease in available provider days, mainly the open office. Total operating expenses for the month were $1,458,646 versus a budget of $1,390,418, negative variance of just over $68,000. Salaries and wages were just slightly under budget. We continue to cover some budgeted employee positions with contract labor. FTEs for the month were 115.1 versus budget, oh my gosh, 105 point. Thanks. Wait for that question. 105.1 versus a budget of 106.8. Contract labor continues to be over, as we just discussed, mainly in the nursing areas, but also in radiology, where we have utilized a tech. We're pretty much utilizing a tech, registry tech, as a full-time individual at this point. Profees Medical, there again was a negative variance in the actual physician hourly rate of 163.8 versus 136.8. This should go away significantly into February as we have Mellon and Scott scheduled more we'll just have to see about how many shifts we can cover with our pool of independent contractor physicians versus the locums. OT, occupational therapy services, was also over budget, but is supported by the additional swing bed patients and the revenue associated with it. The expense for professional fee medical was somewhat offset by a decrease in the use of locum providers, again, the open office. Other expenses, we did find we're able to buy an RN, I guess, in lack of better words, from an agency, and she's now employed with the hospital, and we continue to have housing and travel expenses for the locum providers. Good news is days of cash on hand increased from 76.6 to 84.6, and this was due to the receipt of the Prime Grant funds and the semi-annual property tax payment, as we discussed. When we look at February next month, our February cash, just a rough estimate with where we sit when we close the month or when we ended the month, we're going to be up to 87.5, and we've already made our intergovernmental transfer for the HQAF program. So we'll be receiving the payment back of just under $600,000 probably in May. So cash is finally trending up, and it will continue to trend up for the rest of the year, or by the end of the year we may have some dip in March and April until we receive these supplemental payments. Last but not least, gross accounts receivable ended the month at 4.11 million, which was an increase of 155,000. Gross accounts receivable days increased to 54.8, and just barely under our top of best practices at 55 days. I guess we'll talk a little more about AR, revenue cycle accounts receivable under HRG, or we can do that now. Any questions about the operations?
Not a question, but I think it would be good for the other board members to know why we didn't get the full Prime Grant.
Yeah.
So the reason behind the full Prime Grant is we missed one of the measures on the HCAPS response, which is the response that patients have to give back to us. The Care Coordination Department is doing everything under the sun to get the patients to respond back to the survey. NRC Picker has been helping them. We're starting another campaign with the buttons. How did we do? Karen, what are some of that?
Buttons say we're listening, and it's so they can get recognition of seeing what the buttons look like and what's actually coming to them. It'll have the same coloration, so it's something so they can identify too, so they know that it's something to answer.
Right, so this is one of the measures that a lot of the folks are having problems with, and it's just getting the patients to answer, return the surveys back. So they're also giving them, they've been giving them, they're doing putting it in the discharge packets as well as handing it to them, talking to them, and actually showing them, this is what the envelope looks like. It's going to come in the mail to you. This is what the questionnaire looks like. Because some of the patients, when they do the follow-up call and talk to them, they say, well, I threw that away. I thought that was junk mail. So they're trying everything they can to get that information out to the patients to get them to answer back.
And it is getting better. So we are getting more responses now. And we're letting them know before they leave that they will be getting called and they will be getting things through the mail.
And then the responses, even if they would, because you can't do the responses on the computer internet-wise, because that was a question we had, can't we help them before they leave, get on the internet and have them answer those questions? That's not how the surveys come out. So, and it's also reminding the patients that you're going to get the phone calls as well as the letter. So they've been working on it, but that was the issue.
I think I just missed something in that. So there's that measure. Exactly what is measured? Is it a percentage of patients seen? What is that?
It's the percentage of the patients who return their responses off of our inpatients.
Okay.
And it was a measure that was selected that, in the measures of difficulty, we thought that that wasn't going to be that difficult, what we thought.
And missing one measure, what's the percentage?
On that, the
Financial loss
HCAS,
associated with that?
well, as you saw in here, there was the $20,000 difference,
How much, Linda?
200. And that's because that measure was a year measure. That's not a month loss, it was over the year. We actually had caught up on that measure, or were right there for the first 6 months of the year, and then the second part is where we fell down.
So they don't use an extrapolation formula, they just, okay.
Yeah, it's either you did it or you didn't.
So what percent have to return them in order to meet the measure?
You know, Karen, do you have that? I don't want to tell you wrong.
Casey is on her way, she'll be able to answer that when she comes in, Ashley and Casey are on their way.
Okay.
They're doing something over at the hospital right now.
I want to tell you it's in the high 80%, but I'm
Yeah.
not sure on that measure.
Once they come, that's fine.
Okay.
Yeah.
I did have another question. Are you guys done with that one? Okay. I was just looking on page 2 under the expenses. So salaries and wages and employee benefits, that line 21, it shows a variance for the whole year up to date of 27,000, but just for this month, a variation of 17,000. So I was wondering if that was correct, or what that might be related to.
Yeah, you and me both, actually.
Okay.
There's a way that the payroll's recorded, and we can record, it's not completely synced between the labor expense and the payroll deductions, because, or the payroll related expenses, and so in some months we have higher or lower. There's not always that exact relationship between the two.
And if we look next month, it should be an inverse?
Yeah, you know what I will look into is, what's concerning me is, I will look into why the year-to-date, because after 7 months, it should probably be a little more in line. And so, I obviously under-budgeted something, but I will look at that and I'll give you a report on that.
That's all I have. Excuse me.
Nothing else? Do we have to take action on that report? We don't have to approve it, we have to accept it?
Accept them.
Okay, can I have a motion to accept the financials?
I'll move that we accept the financial report for January.
Is there a second?
I'll second.
All in favor? Jerry?
Aye.
Dana? Aye. Rich?
Aye.
Ken?
Hey,
And I vote aye. Okay.
Are you going to do the finance meeting, try to set a date for that?
Sure.
Well, and before we start talking about that, because we have the bullet point about a special meeting where it's the finance education, and what my question is would it be too cumbersome to kind of combine some of these special meetings and not having that at a board meeting? I heard Jerry, you talking a little bit earlier about bylaws, a special bylaws meeting. I know that we have all the board evaluations done. So we're going to need a special meeting on the summary of the board evaluations and board retreat, that was a better way to put it. So, you know, a thought of maybe combining some of those topics together if they're not too cumbersome and too lengthy, so that we're not meeting today.
How long do you think the finance piece would potentially be, Steve?
You know, with questions and discussion and everything, I'm going to keep it no more than 2 hours. Could be less.
So, and when Linda was referencing the bylaws, it was my suggestion to bring to you about, since we had talked about making so many changes to the bylaws, that you all weren't involved with every step of the way, that maybe we needed to walk through them with everyone before we actually say, do you agree with these or not?
So the question is, can we do that all in one meeting It doesn't sound like it to me, but how do
Not
the
those
other...
three things, I think that's probably too much, but.
Yeah.
We might be able to combine two, and do, actually keep the financial one separate.
Make a start on it anyway, on the bylaws. Do the finance and at least get,
Yeah, I think that probably is more
Okay.
likely what would happen,
Okay.
yeah.
Does that answer your question, Linda?
So a finance slash 40 evaluate summary,
And I think we were talking about finance and then at least starting the bylaws.
Finance, the finance
And
meeting will be
Finance
separate.
Okay.
And then maybe the next one would be the rest of the bylaws and the other things that you were talking
Okay.
about. Are we looking at dates now, too?
Well, did everybody bring calendars?
I do.
No?
Do you want to set dates now?
Either set dates now, or we can, days of the weeks that are better for you.
No, Thursday, Friday.
No, Thursday, Friday for you.
Well, after June, it's fine.
Well, we'd like to get this done sooner.
Well, sooner than that.
Are there days that would work best for you, Steve?
Thursday, Friday, no. Wednesday the 13th in the afternoon. And are we, not to jump up the agenda, but are we set on the board date for this month?
No.
No, we needed to talk about that at the end of the
But
meeting.
We'll talk about that.
Okay, because the 25th would work. The morning of the 18th.
The 13th
You're in March, right?
Yes, I'm sorry.
The 13th and 25th both work for me.
Well, and I would like to discount that whole week of March 18th. Sadie and I have to be in
Correct.
Chicago at that compliance exam.
So does the 13th work for everybody? What day of the week? You said that's a
The
Wednesday?
Wednesday, next
It
Wednesday.
does not work for me, Dave.
It doesn't work for
Oh.
me either. All right,
What about the 25th?
25th works.
25th is good for me.
If we change the board meeting date.
Back to the 28th.
is that the board meeting schedule?
Well, right now, the board meeting, until you have the discussion, it's still, because of last month, you voted to move it to Monday, the 25th of March. That's where it sits as we talk right now. At the end of when we get down to the next meeting, if you make that change to move it back, because the reason why it got moved is now no longer there, then that opens up that date. Or leave the board meeting on the 25th and have your financial on the 28th, which is that Thursday, but then you said Thursdays aren't good for you.
Well, it depends on the time.
Oh,
If
okay.
it's after 3 in the afternoon, it's not a problem.
Okay.
Why don't we just do it on get this out of the way on the 25th and then decide when we're gonna have the board meeting.
I agree.
Okay.
Okay.
Is that all right with you, Rich?
Oh, wait, what?
Yes,
Because we have to do
good.
the board meeting.
Okay.
They're gonna vote.
We'll change the board
yeah,
meeting.
They're gonna.
So we'll have the finance meeting on the 25th.
Will that be here?
Does the time matter?
No.
Since that's a Monday?
No, it's a Monday.
What time do you want, Steve?
That whole day's open after 9, so that's your availability.
Afternoon?
Oh, do you wanna have that long meeting in the afternoon? Probably better in the morning when everybody's still,
It's only
Rick,
about a
what
2-hour meeting.
What about Rich's time?
but then bylaws after it.
No, this is just the finance
Well,
meeting.
and we were gonna start the bylaws too, is what we were talking about doing.
Okay.
Yeah.
It makes no difference to me, morning or afternoon.
3 hours, it's at least a 3-hour,
2 plus.
2+.
Rich, on the 25th, do you have a better time?
No, I'm gonna be traveling, I'm gonna be on the phone, so anytime is okay.
Okay.
Well, 9 o'clock in the morning?
Well, he said it had to be after.
9 works.
Okay.
Okay, 9 o'clock,
Yep.
the
So
25th.
then we're changing the board meeting.
And we'll change the board meeting to its regular scheduled time, because the president messed up.
Is the regular time, we'll go back to the 28th.
Yes, at 3 o'clock. Okay, that's all set?
Okay.
You got all that, Michael?
Yeah.
All right. Okay,
Do you want to
Jacob,
vote on it just because changing the big, or no?
do you need a vote on it?
Yeah, I think you should.
Do you want to vote now, or do you want to wait till we get to that part of the agenda?
We can,
Well, we can do it now.
let's vote now while we can still remember what we're voting on.
All the finals.
All those in favor of having the special meeting on the 25th at 9 a.m. and the regular board meeting on the 28th at 3 p.m., vote for or against. Jerry?
Aye.
Dana?
For.
Rich?
Aye.
Ken?
Aye.
And I vote aye. Okay, Jacob, contracts?
I've already tabled this pending further evaluation of our infrastructure.
Didn't we table it last time?
Can I ask a question about it, though?
Yes.
While we're on it? Thank you. So, in looking at the two proposals from the two different vendors, am I correct in my interpretation of the SHI equipment as being similar to the equipment that CSI provided with the SAN, the SAN?
Storage area.
Yes.
network? Yes.
Okay, but SHI did not provide a part of their quote for setting that up? Is
The
that right?
second piece of their quote is what they want just to set it up.
Second.
There's two pieces to that. One of them is just.
That's why there were two
equipment.
different price amounts in here then. Okay, that was my other
The second price
question.
amount that you have there
Okay.
is what
They want it
SHI
just for
proposes
the-
just for the scope of work.
Okay, thank you. That answers my question. Both of them.
So, what is the bottom line for each of them? Could you,
The recommendation that I have pending the completion of our internal infrastructure assessment is approximately $85,000.
how much?
$85,000. And with moving forward with this, this will be a 3 to 5 year investment, as we won't need to buy more licenses, buy more equipment, buy anything else. This will ultimately almost wrap up the entire facility's equipment upgrade needs for at least the next 3 to 5 years.
And will the SAN improve our speed, our data transfer speed as people are accessing information?
Yes. It'll increase speeds, and it'll also provide for redundancy. As Dr. Walls found out the other day, we had one of these servers had an internal malfunction, and it took several days to get it back up and running. And during that time, some accessibilities for in-room patient care and things that they do over here in the clinic now was not available. So the redundancy will provide the ability to not have that happen again. If one of the physical machines was to malfunction, the storage area network and the second machine would automatically pick that up and keep everything moving along until the first machine could actually be, the physical machine could be repaired.
Okay. So then once you actually finish your infrastructure analysis, then what we're looking at is the second CSI proposal, right?
That is my recommendation, is the recommendation for CSI, and we're waiting on the completion of that for any other recommendations that we might have.
Thank you. The next item on the agenda is the CEO incentive. Yesterday, talked with Linda briefly, or she talked to me briefly, and we really didn't break down the difference between evaluating for the salary and evaluating for the bonus. But you have in your package, and I hope all of you had a chance to look at it, what Ken and I came up with. We plagiarized a lot of it, but we also tried to make a lot of it pertinent to our institution. And I think what I would just like to do right now is just open it up for discussion amongst the board members. And Linda.
And I also provided you with some comments that I had when I reviewed this and looked at this. This to me was an excellent way to evaluate annual performance. I think it's a little cumbersome for the bonus incentives, because when you look at an incentive program, there's usually only 4 to 8 goals to meet. But when I looked at this was a better way to do an evaluation, an annual evaluation. I was really impressed. I did present in the packet that I presented to you the current job description with the current evaluation that we've been doing. And then I also added what we had for the incentive, and of course that was the 217. And the other comment that I wanted to make is when we present the strategy map, which is next on the agenda, maybe we can pull some of those pieces from the strategy map and move that over and use those for the CEO incentive. The strategy map is mission vision driven, and it's also strategic planning.
We could easily pull out certain objective criteria for a bonus, separate from an annual evaluation. That would not be difficult to do.
Right, and I wasn't sure because there's some things in here that was italicized, and I wasn't sure if that was the piece that was supposed to be part of for the incentive, but I just wasn't sure. So that's why I went ahead and did my packet for you.
Yeah, well, some of this we wanted to emphasize more.
And that's good, so I know.
Financial leadership, there were some definite objective criteria in there. And the same with quality measures, there were some objective criteria. In particular, I think, I won't speak for Ken, I'll just speak for myself. Med staff surveys.
Where are you?
Under quality and patient safety, I think that's page 4. Page 4. Using quality outcomes and objective data, employee surveys, patient surveys, and med staff surveys. I think those things I would like to emphasize, and assure adequate staffing. And then on the next page, financial leadership, we have some things, some information that we got from Steve as to criteria. There was one that was left blank. Steve, have you given any more thought to that? Operating margin losses?
Page 5.
Yeah, that one's really going to be predicated on the budget we create.
Okay.
So we can come up with a target now, but it may not be realistic when we create the budget, so that one's going to have to stay open for a couple months.
Okay, but we could pull these types of things out of here and then use the rest of this for a salary evaluation.
Exactly. And the other thing that I did add in here, and now that I think about it too, Jim and I had been talking previously about doing a direct report evaluation. So the staff that directly report to me, to have them do an evaluation of their or how they feel my performance is. And I think I would like to add the med staff as well. I'm maybe not wanting to add that, but I think that would be a good idea.
No, I think that's what I included, was the medical staff.
I think that would be, because if I as a CEO need to interact with the medical staff, yeah.
Where's the medical staff piece of it?
On page 4,
It's the 1, 2, 3, 4th bullet down.
uses quality outcomes, et cetera, and then state and federal performance reviews, quality assurance data reports, med staff surveys, patient surveys, and employee surveys.
Yeah, that's further.
We, when Ken and I talked it over, there was, I will just tell you, my personal feeling is that people that you hire and you pay and you evaluate for their raises, I'm not sure how valid that is in evaluating your performance.
Well, and I put in here anonymously, so that then the HR
Okay,
director has to
well,
do
somehow or other
the
it can be
summary.
incorporated, yeah.
I have a general comment on this financial leadership, which I guess is only 12%. Maybe it should be higher. The number one thing is the capital budget. I don't think that should be first one on the list. The second one is the one that we can objectively measure, is whether you're meeting the budgetary goals of the organization. That's the one that follow, I don't know how you measure that at all, sets the tone. I don't know how one determines what a tone is. Dave, what did you think about, like, setting the tone? Adequate systems, opportunities to strengthen. How do you measure that?
Yeah, it's kind of tough, but I think
I mean, meeting
the emphasis has to be on getting ancillary services to drive increased revenue.
Yeah, okay.
I think these are kind of cultural aspects also. If there's a sense that what the tone is for financial discipline in the organization. And as board members, sometimes we get feedback from people, that says, yeah, we're doing a great job in this area, or we're not. And so each individually, we can kind of assess what our sense of that is.
Okay, I'm just looking at it from being a former hospital administrator. If I was being judged on things that were so subjective and didn't have a way to be measured, truly measured, I might have a problem with that. And meeting the budget is that's objective information. You can measure that.
Well, I think that's what we're discussing. That's why we decided to bring it to the board. The percentage, how we break this down into what percentages are more important, I think the board has to make that decision.
And I can appreciate that you guys put a lot of time and effort into this too. Thank you very much for going through and doing this.
If you want, we can pull out the objective criteria and use that for the bonus.
Yeah, 'cause I did have some similar questions as to Rich's, just because a lot of these are definitely things that we want to encourage, but I don't know how we measure them. Like, looking on page 6, encourages open communication and dialogue with physicians. I agree that's very important, but how do I as a board member know if that's occurring?
Some of that, I think, historically, it has been done through Linda's self-evaluation. She tells us what she has done in certain areas. And then we can also get feedback from staff and physicians about what their perceptions are.
Well, and that's one of the reasons why you have board members at the joint conference, is because at the joint conference meetings is the time when you have that open communication between the two board members, the physicians and myself. That's why staff is excluded at joint conference. So the physicians don't have a problem of telling the board members during joint conference if there's any issues. So that, I guess that's one way of evaluating that as well, that you as a board get to hear it from the physicians themselves. And then with the component of a board member sitting in those medical staff meetings, that's the other way of the board being aware of what's going on between the medical staff and CEO and staff. It's because you hear it directly in their meetings.
I think also the evaluation isn't just about money. The evaluation is also a time to have a dialogue between the CEO and the board and discuss these more subjective things that emphasize attitudes and emphasize goals and things of that nature. It isn't just about, well, we're going to give you this 3% or we're going to give you 2%. It's also a chance to have an intimate conversation about where we're going and how you're performing, and just have a real candid conversation.
We only have 3 months. The first evaluation happens 3 months, and so that's due the end of March.
Well, now's one of the things I wanted to clarify. So I was brought on in a full-time status and past the interim and permanent status in September. So that's truly when my annual evaluation should be, in the September board meeting. Then when it changed and the incentive was added, somehow it changed to where the incentive, every 6 months for the incentive was June and December, and then we pushed the evaluation to December because of the issue with making sure all the financials were in, and we trued up from the cost report. And so that's when the evaluation moved to December as well. And so one of the questions I had was the clarification of, are we going to leave the evaluation in September and leave the incentives in June and December, or was the evaluation going to stay in December and move the incentives? I was unclear on that.
Well, I thought we voted.
I thought we discussed that, didn't we?
And to go to March and September.
Didn't we already?
Yeah, we did.
Isn't that in the minutes?
In the last
We looked at the
meeting.
minutes, I didn't bring it with me.
Yeah, we did, we discussed it, and we went to March and December,
Okay.
I believe, and the only question with that, of course, is you only have 3 months right now we're supposed to be doing it at the end of this month.
For the incentives.
Yeah. So, that's one thing. I just have.
I think, Michael, you're gonna have to, yeah,
Excuse me.
go ahead.
Okay, I just have 2 other things. That grading is almost always subjective, almost always. The only thing is, like Rich says, if you're talking numbers, even those can be manipulated. You're gonna see that, and that makes it harder. You're always looking for a good place to start, and I think you guys have developed a good place to start. As we go along over the years, as the boards go along, they'll probably make changes. But and I still am. I'm not a fan of personal attributes. I think that smacks of, is she good looking or not?
Dana, I'd let you know that Linda has sketched that out here as well, but professional, and I'm okay with professional on that.
Okay, all right.
Sorry, I did it.
So Linda, can you talk about the changes that you were suggesting?
All that I virtually did was,
Rich, then we'll send that to him.
Rich, Michael was saying that she didn't send that to you, so she'll send you the changes that I had put in here. And all that I did was change this to the appraisal process and assessment program, so that this whole piece could contain both an annual evaluation and the CEO incentive criteria. So I added some changes to identify that it's both an annual evaluation and incentive programs. And then the addendums are the attachments. One would be the performance eval, and 2 would be the incentive criteria to put together. And then I just further defined under the CEO evaluation process, again, that is annual, that there would be a direct report evaluation, that, and under 3 I put it down lower, that it would be anonymous, that HR director would direct that to those direct reports. And then I just now added medical staff that you guys don't have, after looking at it, because I think that's an excellent idea. And that summary of the anonymous CEO performance eval from the direct reports and the med staff would be brought back to the board so the board can review. Kept all the rest the same, that of the evaluation process, and then I added the CEO incentive evaluation process, which should be followed the same as the evaluation, but it's a 6-month incentive.
Can I ask you one question here? On page 2, you said the HR director should provide a summary, provide the direct reports anonymously. I'm assuming the HR director gets the reports anonymously.
Right, I would not see them, Michael would not see them.
But they wouldn't even know where they came from, correct?
Right.
And the question is, would the board get a summary, or would the board actually see a summary and the comments?
And that would be at the direction of the board. I just wanted to clear that.
But that just wasn't clear to me.
Right, and it would not come to the administrative office, it would go to HR, so that the employees, to your point, the employees would feel comfortable doing a true evaluation, because it doesn't help me if people just tell me what they think I want here. I need to know what I need to work on.
Appreciate that comment.
Okay, it sounds like we better make some decisions here. We're gonna need a little more time.
Can I ask another question too?
Yeah, that's all you want.
The intent for the summary report that you guys have on here on page 2, is that summary report everything, including her direct report piece, or is that just the board summary report?
I'm sorry, I'm not.
I'm sorry, on page 2, the original number 3 bullet point, where it said summary report, evaluation we collected from the overall board performance rating. I think you meant for that to be a board summary report, correct?
Yes.
Okay, so we may want to clarify that since we've added direct report and hospital medical staff pieces to that.
Okay, so where do we go from here?
I just find it reasonable for you in your spare time to meet with Linda, you can look, you've got any, opinions around here. It seems like it would be easier for 2 people to do this now than.
We can do that. We can do that, that's what the board wants.
And I think unless I added incorrectly, I think our 12% percentages add up to 60%. Is that right?
Well, that's the way we save money.
I wanted to ask. I didn't know if the other 40 was.
No, I think we were aware of that. We were still toying with the
Okay,
percentages as we did this. And Rich mentioned, he was mentioning that maybe the financial fee should be more than 12%. So I think we can play with those.
And I'll tell you-
I wasn't sure if maybe the rest was supposed to be for the second piece in here.
Well, and we struggled with that. That's how we divided this up.
Yeah.
And I'll tell you another concept that came up. As far as grading goes, where we plagiarized some of this from, they had a 1 through 5 score. So each of us would vote 1 through 5, then add it together, and then we would get a set number. Now, the question is, if we add it all together and it comes out 4, does that mean that we award 80%? Or, Rich mentioned to me, is there just a passing grade and you get it all? So that, I think that's something else to consider.
But that becomes more meaningful to pull out certain ones for incentive.
Right.
That's interesting.
Well, and I think it comes back to your scale too, right? So you don't necessarily expect someone to get a 5 exceed expectations, and that's how they make 100%, right? You would want them to exceed expectations, though. You want to reward that somehow. So, I don't know the answer to that.
So, one thing that might help too, is you're introducing me to my evaluation of CEO and from, I do evaluation on Jim as the HR director. Jim is set on a salary scale, so unless I've done some performance, or he's had to have some performance issues addressed throughout the year. And so I go through this evaluation and he has meets or exceeds. He's automatically getting this 4% increase because I've not had anything throughout the year to tell him he needs to work on anything. So he will automatically, for his salary, get a 4%. That's how it works for all the employees, is that on that salary scale, it's a 4% while they're being assessed. Versus for me, it's not an automatic salary scale. The board then looks at, my evaluation, my performance, and then what percentage increase, are you going to allot to give me? So that's going to be the difference. So when you're looking at a salary scale online, that truly will help you to decide which sort of percentage versus when we do the salary scale for the employees, it doesn't matter. They get that increase unless there's been a performance improvement plan put in place for them throughout the year. I don't know if that helps you or doesn't help you, but that's how it works.
Well, and also, I saw the forms that are used to evaluate the 2 employees that are in my office. It's about 4 pages long, and it is very subjective. And those employees don't know ahead of time what their goals are. I mean, there's nothing objective set out for them, and yet it works.
Right.
It works.
The evaluation is basically right off of their job description. So their job description, which they all have, is based, if you go through line by line on that job description, did you perform or did you not perform? Are you meeting this or are you not meeting this? And I think some of the things that you say are subjective, your situation is you don't see her working every day. The manager sees that person working every day and knows whether they've got a good attitude or whether they got a bad attitude or whether they're doing what they should be doing. So they know that they can handle a little bit more subjective things than say you guys could for Linda.
You know what? You're wrong.
I'm
You
wrong.
are clearly wrong.
Yeah.
The manager almost never sees the work day today in my office.
On the day-to-day.
No,
Yeah.
no. And how often are you in my office watching those people work?
Right.
You're not in there daily, in there
Right,
watching
right.
them, because they function, they do their job well.
Mhm.
She tells me this all the time.
And usually we have to worry about, what we're dealing with is, if you're satisfied, we're satisfied. You know, if the doctor's satisfied, we're satisfied. And that's how we usually approach it.
Dave, the bonus for the CEO was set up as a package of salary and bonus, and the bonus was to be given if the CEO met expectations or exceeded them.
So it's
Didn't have to score a 5 to get the bonus.
So it's an all or nothing bonus.
No. I mean, the board could decide not to give the full amount if the CEO didn't meet expectations.
Okay.
But they didn't have to exceed expectations to get the bonus.
I think he's suggesting a 4 or 5.
Yeah.
That's what I'm suggesting, yes.
Doctor, can I just throw in my 2 cents worth just from,
You might as well.
well, because this reflects directly on the hospital, because you've got, if you come into the hospital, you're going to evaluate the hospital based upon what happened. And see, I'm one of those people that if it's a 1 to 10 or a 1 to 5, you're never going to get a 5 and you're never going to get a 10, because there's always room for improvement. And that's just how my mind works. But there are people on the other end of the spectrum that say, oh yeah, that was really good. You know, and it's right down the line, 5, 5, 5, 5, or 10, 10, 10, whatever it is. And that's where the subjective aspect comes in, because it's human nature, and I believe that everybody on this board are humans. I don't think we have any aliens. So you're subject to the same things unconsciously. You know, if you've had something, if you're one of those people that hangs on to something a long time ago that happened, you're like, well, I'm not going to give them a 5 this time, I'm going to give them a 4. Yeah, so it's one of those things that it almost has to be. You set down the criteria, they meet it, they get it.
Okay.
I think you would talk about our percentages, but that's something we'll probably bring on, right?
Yeah. Did you have something to say?
Yeah.
I'm going to bring this to an end here pretty quick.
Dave, I have one other suggestion on page 2, number 7, the
I have no more. Go ahead.
I don't think the board chairs should do this alone. I think there ought to be 2 board members when they talk to the CEO.
Okay.
That's my suggestion. I don't know what the other board members think.
I think that's a good idea.
Yeah. Okay. David, what were you going to say?
Well, I think you can do pass or fail when you do the evaluation, but I think when you get to the incentive, the knowing the ratios is a good idea. I think they're 2 different things. If you want to keep it simple and quick, you can do pass or fail on the evaluation.
Okay, so I think that the conclusion we make here is that 2 board members, myself, 1 other board member, will meet with Linda and come back with a final report the next meeting. Do you want to? Okay. We'll get together, Mike will get together, so.
Do you want to have us talk about what percent to assign each category, or you just want to?
You know what, why don't you make suggestions and give them to us?
And what about the March, in March? Are we committed to that
For the meeting?
no, for the evaluation? That's what we decided before, we were gonna do it in March and December. Are we gonna change that?
I honestly don't recall what we decided. I think we need to recheck that. I'm sure we made a decision, I just can't remember what it was.
Yeah, we looked at it yesterday, right? Well, and
And if we already made the decision, we should stick to
Okay, one of the things that makes it really problematic when if you're doing the second half of the incentive during the evaluation, that's where things get a little mixed up, and I end up giving you two documents that are virtually the same. That is really confusing for the board. And that was why when I was looking at it, I couldn't remember if we had decided, and I even said to separate the incentive dates from the evaluation dates. I do remember, Jerry, now that you said that about truing up the evaluation. So that will be in September because that's the true update for the evaluation. So that might be something you want to think about because one, we're pushing it, and I'm okay with this, because we're pushing the dates for the incentive expectation was supposed to be set back to the DCAR. In the past, we had done the June and the December. It will give the board more time. It doesn't really make that much change when it comes to the incentive, and when you talk to money, because that's what we're doing during the incentive part, that doesn't really change for me. So, I mean, that's something for the board to consider as well.
Yeah, you better find out what we voted on.
Exactly.
Okay. Well, I knew this was going to take up a fair amount of time, but I think we can move on now. So it is set. Ken and I will meet with them and we will have a final plan. I would encourage all of you who have ideas that you want us to discuss, email Michael with your suggestions and we will discuss it. Come back with a final report. Okay, moving on to the strategy map.
So we had a meeting with department managers. We had John Peckham come in and we were looking at the strategy map for objectives for the facility with the managers. So we looked at what were some of the key components that as a team we wanted to see. So John helped us put this together with, you'll see it aligns with our mission and our vision. And we have 4 key pieces that we want to look at to move forward with. So that's the financial objectives, the patient, community, and partner objectives, internal, clinical, and business process objectives, and learning and growth objectives. And then with those 4 major categories, we picked some subcategories to look at how can we improve the organization. So this is what we came up with, and we did get some outside external help from John Peckham. And we wanted to present this to the board. Use it, not
That office broke out.
So when I look across this, and it seems reasonable to me, there's a lot of minutia behind a lot of these processes that we're talking about. Have you thought about using some logic models to walk through this, given what that minutia is? Are you familiar with logic models?
Yes. To that point, our next step was to set up a balanced scorecard, which will use those models to get to that balanced scorecard.
Okay.
So, we were thinking about that.
What's the use, what are you using this for?
So what we're using this for is so we have a clear direction, because the board has to have a clear direction to see where, IMCO is helping the staff to move forward to meet these goals. When you get to the balanced scorecard, and I have a balanced scorecard I'm going to show you, it's red, white, and blue type of, it's a way of doing a quality measure where there'll be colors to repeating these measures. So that you have a one-page document that shows month by month. And so, for example, under financial objectives, improving the operating margin. The net revenue is the net revenue as a percentage of gross revenue. Are we meeting that number that we put in there? Yes or no? When you get down to patient, community, and partner objectives, we were looking at the primary care physician, nurse practitioner, and our PA retention and turnover.
What's the difference between this and the evaluation? Aren't these?
This is a facility-wide. This will help you evaluate my performance. I guess is the best way to put it. We are trying to put all these pieces together that, and some organizations are already there, we're just struggling to get there. And this is just another piece of that puzzle.
And to your question, yeah, I think this is just a good roadmap for everyone.
Why do we only say enhancement of existing services? Why not new services?
I think the thing there, Rich, is that it's because it falls under a financial objective, and it's already something we're doing and providing, and it just means that we're going to do it more efficiently or more effectively. If we want to, I think it's, when you start getting down to patient, community, and partner objectives, you talk about improve access to primary care and an appropriate range of services, specialty care services to meet identified community health needs. That's where we talk about expanding on what we're currently offering now.
But to Rich's point, maybe the word existing is not necessary in that.
Yes, I like that. Eliminate existing.
Okay. When we talked as a team, we had it in both categories. We had it as existing services, and then we also identified it as new services, and these, like, we lumped it together, and maybe we weren't clear enough with it.
So this was an information-only discussion.
At this point, yes, we're gonna keep moving forward with, getting the benchmarks for this as well. We just wanted the board to see this so that the board is aware. Would have liked it to be a board approval, that you like where we're going with this and we can continue on moving down this road.
Do you want a motion to approve?
I would like that better than just information only, that this is the road the board is directing us to go down.
Any input from the board members?
Understand.
Does anyone want to make a motion to accept this? Or do you want to think about it for a while?
And that's fine too.
This is the first time that
It is the first time you're actually seeing it, other than when we send it out with the board pack.
would you like to have it on the next agenda?
Table, I'd like a table, yeah.
Okay.
Once we do finalize it, will we put this on our website though? I think this would be a nice
Yes,
thing
we
for
would.
the community to see.
Once that's finalized, then we move forward with that balance scorecard, part, that would be on it as well.
Okay. Got that, Michael? All right, agenda items here, capital budget.
Mind if I say something?
Sure, go ahead.
Steve, I want to tell you, you know, I've been, looking at your heels for several years about this, and what you put in here today really, I think is a very good job, and, I thank you.
That means a lot to me. Surprised, because I'm curious what we've done to enhance what we've previously done, so, but we'll take that, but,
We could talk about that, but you've included a lot of things that the board has asked for. I see expenses out across the years. I see what is done, what it's cost us. I see at the bottom the definitions that you're going to support board restricted funds to support this, capital project, board restricted funds to support this. All kinds, these are all questions that have come up a lot of times.
Okay, but what is it? Is it a proposal?
frankly, it's an accounting of what we've done and what we know. It's, as I said in previous board meetings.
I don't know that we're gonna approve $300,000 for a emergency department EHR.
Right, and we're not asking you to. We're just.
Well, what is the document for?
The document is to project our capital needs at this point. You know, Rich, if we want to just pull this out until we bring back an actual capital budget for you to approve, I'm absolutely fine with that. I'm just trying to keep you guys aware of the
I
things.
just don't want it to be mistaken as an approved capital budget. This is your proposal that you'd like us to consider.
Yeah.
Yeah, Rich, in the agenda, it does say it's an updated draft under information only.
Yeah, but I just heard a board member comment on how she liked the capital budget. And I don't consider this a capital budget. This is a proposal of how the hospital may want to spend money in the future.
You can call me Dana.
So Steve, under where it says capital improvement plan, we could hold that and make it a little bigger so that we see that this is a plan, not a true budget, and identify that this is our working.
Projected in
Yes, thank you.
Okay, and
So Linda, you're asking for 300,000 for the
No.
EHR next year?
No, what had happened with this is, as what we're trying to express, is that this was a request, the emergency department EHR, this was a request from physicians and from that department to get that emergency department EHR at that cost. We're not saying which EHR. So it's not identified as this T-system, as this CPSI, as this. We're just trying to do a placeholder to show that we're gonna need something in the ER that's gonna be more robust than what we have. So whether it's purchasing the CPSI EHR model,
Okay, have we decided that?
no.
That we want to invest 300,000 in the EHR and ED, whether it's CPSI or anything else?
Correct, we just use that number as a placeholder as we have done with some of these other items in here.
yeah, Rich, this format will go away in a couple months. What is at the beginning of the meeting when there was a question about an incomplete statement about this last time, is the intent is to bring forward a true capital budget for fiscal year 19-20, where we identify the needs we have, and it'll be a 5 years. So yes, some of the things going out beyond what we're asking for 2020 will be things like this, where we're saying these are things we've identified, but we're not committing to. We're asking you to commit to 1 year, and that's what we'll bring to you here in the next couple months.
And this was also one of the first stabs of making the department managers be accountable for what they wanted for capital. In the past, it was the administrative team that pretty much looked at what we needed, and, you know, we would get the input from the department managers and medical staff. We truly made the department managers responsible for what is it that you need that's capital in your department. Tell us, we need to know. We asked the med staff, what are some of the capital items you would like to see? We did this the last year and a half that we had not ever done before because we didn't have the money. We had the money now, so now we're involving the entire staff, medical staff, department managers.
So right now, this is just an update. Anything over $25,000 that we propose to spend on this year, we bring to you guys. Anything we want to use board designated funds. Capital policy is $5,000, so anything over $5,000 that we want to use board funds, we'll bring to you. And on the second page is a summary of the items that we've brought to you guys that that you all have approved for use of board designated funds. And that amount has been removed from the 150,000 has been removed from the original 500,000. And one of the things I think we also need to do is when we have the finance education program is to do a couple housekeeping things, such as define what the true definition of these board funds, and to Ken's previous questions, do we want to have an actual designated operating reserve, emergency fund reserve, and those types of things.
Does that answer your question, Rich? Yeah.
For now, Rich.
Okay. Can we skip governance education since everybody's started their evaluation then? or-
Well, the only thing I need to know is, well, number one, now that we have evaluation, we'll get the summary back, and you as a board need to look at the summary, and it's your evaluation of each other, so we need to figure out now what we're going to do with it. So now is when earlier I talked about SHDBOARD03, something to put it together so that we use this information, and this was something that you did for a purpose, not just.
Do you have any idea how long it'll take to get it?
She said next Tuesday I should have some next week. So once we get it back, maybe we can send out a query as to what was worth, and again, that was why I asked about different dates and trying to combine things, and then not want to beat you to death, but I know that that piece is going to be something that we need to do outside of a regular board meeting. Because I really want it meaningful and not just, check the box off so we can move forward to getting certified as a health service.
Yeah, you can just send us suggestions.
Once we get the summary for you, so. And thank you for getting all of that done.
Okay, Steve, you're up again.
Okay, this is the HRG report. I mentioned in my finance report, the AR days did grow a slight amount. They were just barely under the upper limit of our target of 55 days at 54.8 days. Got a few things going on. Because of our inpatient, some of our inpatient and swing bed stays, we have a couple very, very large accounts. We have 2 accounts that total about, this is not in your materials anywhere, $417,000 just off of 2 accounts. And that's approximately 5 days of AR just in 2 accounts. So if those 2 were settled appropriately, we'd be down around 50 days. We have 14 accounts that account for just over $1 million. So we got some large accounts that just take some time to settle. The patients are here longer, they overlap months. Those are not excuses, those are the reality. We do have in there some older accounts that still remain inpatient swing, that were victims of our past sins, both ours and HRG's, that we're still trying to resolve. They did show some improvement in the Medi-Cal, so that was good. Bottom line is we're still not where we want to be. There's no debate there. HRG was scheduled to come on site here last Tuesday. I don't know why they couldn't get here, but I guess they don't care about us enough. So we actually told them not to come. They will be here the 18th and 19th with the intent that we will sit down with them and go over our issues, and we'll create expectations for the 1-year contract that will be, extension that we'll be signing with them, that will include, at you all's recommendation, some discussion about incentives for performance. Rich, I understand what you're saying, but I think the way the contract's written, we give them enough money that if they do a good job, they make really good money. But maybe we have to build something in there. We'll see what they come back with. But absolutely some penalties for not doing their job. We've met with the revenue cycle team, and they're giving us their feedback so that we can include that in the expectations. And the idea is that we'll create an addendum, if you will, to the agreement that outlines the expectations and their performance standards and how that would affect their compensation from Seneca. So that's where we're at that. Any questions or comments or input? Yeah, things are improving. My goodness, we've we've worked really hard to hold them accountable, and I don't know if people have quit over there because we have experienced turnover. So, just, we won't discontinue that, and now we'll have a means to, determine over the next year that where we want to go with this. As far as, you know, if we're just not seeing progress, because we're at the point now where it's almost on them to do it. So, so we'll have a basis. It's kind of, not to overlap here, but with the balanced scorecard, when you have somewhat objective measures that you're able to, and you're monitoring it on a monthly basis, you're able to react to it, and we'll know right away. If we don't start seeing continued movement of the AR days, then we'll know that we're just going to have to seek an alternative solution. But that's where we're at.
Any other comments, questions for Steve? Casey and Ashley are here now. So there was a comment there.
So the question was, we received a less reimbursement from the grant, prime grant due to those, the HCAP measures. So what is the percentage that we have to meet of the return of those surveys?
It all depends based on our last submission.
We'll
There's a
have to-
threshold that increases or decreases, and I'll have to look what the actual number is.
They survey 100% of all inpatients, and then it's based off the strongly agrees? Yeah, so then those that strongly agree how well we are, like how well, you know, based off of, I think, 3 questions, then we submit those numbers to Prime, but Prime sets our thresholds. So we're just getting ready to.
So it's a variable number.
We were talking about a percent of people having to respond, that being the measure, but it sounds like we're talking about something else.
Right. I look at it as, is the percentage of people who respond, and on top of that, then the percentage of the people who responded, and if they respond, I would.
I strongly agree.
That's a huge difference than what we were talking about earlier.
It's really hard to get the number that we need, because not only do they have to respond, they have to respond in a highly.
Kind of like Dr. Wall's survey was talking about, like not only do they have to send it back in, but they have to give us 5 out of 5. You know, they have to, there's like 4 or 5 different,
There's 3 different question categories, and it's, we were just looking at them.
we were just going over it before we came over.
Healthcare performance, if you understand, like something with medication, facility, and then health performance or something like that. I don't remember exactly.
But they have to give us the 5-star, you were great, to count. Not just, they have to respond and say they strongly agree to the question.
So they'll get the survey with 25 questions, and they're targeted with those 3 questions. So if that survey comes back complete and that patient didn't target that question, then it's out the door.
So how does that compare to our prior roundabout, our prior go with this then? So are we getting lower numbers than we did last time?
No, we're pretty much on the same low across the board. We just started, we're listening to promote that HCAP survey instead of, we want to hear all departments in the real-time feedback, but we're strongly encouraging, we're listening with HCAPs, and we put them in discharge packets now. We have little cards that go on every clean bed to tell them. We're getting pins so the nurses can say, hey, yes, this is for HCAPs, this is what we need you to fill out.
We're showing them HCAPs before they leave because it does come from a third party. A lot of people get it and they think it's junk mail. So we're showing them, if this is what it is, this is who it comes from, this is what it looks like, please fill it out, because it has to come from NRC. We can't.
Yeah, but I guess I wasn't entirely clear. What I was asking was, so this time, say we had 2 patients respond, and one of them said we did great, and the other one didn't, so we didn't make our target.
Right.
Last time, if we had 2 patients, did both of those patients say we did great?
And then your threshold goes up.
Okay,
And then so
How much does it go up?
a percentage.
A percentage, Prime calculates a percentage, it doesn't tell us how it gets the percentage. So we submit all the data and we say, this time, this many said we did great, this, you know, even if this time 3 people versus the 2 people, and Neiman on the backside goes in, they calculate the percentages, once it's locked, we can go in and say, okay, threshold next time is, you gotta get 4 people to
But
say
they-
we're great.
They want you to improve every time, so say our threshold went up from the last time because we had so many respondents, and now we're getting ready to submit again, and if that threshold wasn't met, it should go back down into a ballpark range that we can meet in the middle.
This is our first time using one of those measures, correct? Correct. I just wanna make sure I actually have it.
Yeah, and that's one that's out of our hands. And a lot of people, I mean, a lot of people are elderly, and we went to a conference a month ago or so, Flex, and everybody's struggling with it. Across, yeah, California is just struggling, and there's some people that have a high, population of homeless, and they're taking the hit on all those people not returning them. So we're doing the NRCs. Lindsay ordered us buttons, we're trying to push to send it back, started doing it for
Yeah,
them.
you guys are doing
I don't
great.
know how to get them to do it.
It's not launching on that one, so.
Welcome to California.
What was the question? I'm sorry, I didn't hear you.
Oh, no, I thank you guys very
Oh.
much for explaining that. I was just mentioning that comes back to the point that we talked about
Well,
several
budgeting
times about
perspective.
how much we can really truly rely on
Yeah.
these funds, so thank you for
Yeah.
that.
Okay, thank you. Let's see, committees, is there a bylaws committee report at all?
Well, I think we talked about that earlier, but
Strategic planning,
Well, the 2 meetings that we had set up, we had to cancel because of weather, and then both the asking and working meetings we set up and we canceled because of weather, so we're trying to set up some more meetings for March.
okay, so there are no
Weather.
dates now. Okay. CEO report?
Okay, I'm gonna cover some things that I don't have on the list here first, and then I'll get the list so I make sure I get everything. Linda McCree, I wanted to start with you and the disaster emergency truck, all that we've been doing. The first thing I wanna say is that our staff works really well in disasters. We've seen through the fires now, the snow, pestilence, floods, that we've just been working as a team really well. We just seem to be hit one after another, and it's just been phenomenal. So
A little bit interesting here, going back over the records, you know, we always have a sizable binder of documentation for disasters. But last year I had 2, and almost went into 3. And I went, well, now I know what we've been doing for the last year. We've been a little busy, you know, we've had some communication issues, we've had some planned DHR downtime, which we used as disasters. We've had the Wilson Lake fire, which is potential for evacuation. We had the campfire, and it seems like it just kind of went on and on and on. There were a lot of small issues, but it took up a lot of time. And of course, this year is starting out in a similar manner, as we now have run into some severe weather and power outages and things. So my hat's off to the staff. One more time, they're extremely versatile. There's a gentleman sitting in the back room who was the Uber driver and the tow truck operator for a good portion. Terry helped staff get here when they couldn't, and was outside with the tow strap and a few other items trying to get folks up the road and folks unstuck up now. I will say I've never seen in my history in Chester, no matter how bad the weather's been, an issue with the county roads like we saw Wednesday and Thursday. My staff worked very hard to keep the snow moved on the hospital premises and to provide good access here, and the place was relatively clear 24 hours a day. But when it came to the streets, I was extremely concerned. At one point, I picked up the phone and called the highway patrol and declared an emergency because I had, as Casey will tell you, I think she was vehicle number 8, that was stuck out on one of the roads, and we had a trash truck and multiple vehicles stuck on this one, and I could not have gotten an ambulance here. So that's when I pulled the plug and I picked up the phone and said, we have an emergency. I need you now. And and they reluctantly showed up shortly thereafter to open up one road into the facility. And that's something that we will be addressing, because it really concerned me that they could clear the elementary school, which is important. But for some reason, the fire department and ambulance, a road into the hospital, and a road to the sheriff's department was not as important at that time.
Do you think there's something that the board needs to support?
I'm not entirely sure, Jerry, if they had an unusual occurrence. So if they did, we'll see how things go. If it was not that, then yes, we'd like to voice our opinion, that we believe that access to a hospital is a priority. Otherwise, why do we work so hard to keep the building open, but yet nobody can get here?
Yeah, I heard through the grapevine that the ambulances couldn't get in.
Right.
And I was gonna ask you whether that was.
Oh, yes.
True.
It was an issue for us. They could actually get here most of the time, but at one point, they would not.
Because of that, the people walking
The roads and the roads.
And Sherry Thrall is aware of it. I'm trying to get a meeting set up with her so she can hear our side of it as well. And then she'll go to the board of supervisors and give the assistance. And I'm not
That's your
sure.
starting point right there.
Exactly. And I'm not sure if it was a combination of Sherry Thrall was notified, Linda called, both Linda and I called Highway Patrol, and they then made some movement. Not sure. We just know that finally we got some assistance and it got clear. So, we'll let Sherry do her magic first.
Yeah, I know they don't have enough drivers for the county.
And that could have been what the issue was.
And we don't have access to Caltrans to help out for them.
I don't know if that's even a possibility, state versus county. I couldn't tell you. I can't answer those questions, only they can. I thought if they were short-handed, maybe they were a little more proactive with their planning, but I don't know what occurred. I will say that our staff did a wonderful job. Folks got here by carpool. When you hear the staff walk through the door at 6:45 in the morning, everybody who was carpooling in the cars laughing because they drove over a tree to get here. Then you know what they went through out on the road in order to get here in the morning, and others were walking in with lanterns in the dark, and like I said, others stepped up late and went and got those that couldn't get here, so it all worked. And we did very well.
I'm sorry, larger sense, it's just not the hospital getting here, not the ambulance getting here, it's the ambulance getting to residences.
Absolutely, I'm sure that was a terrible issue also.
So was the,
Creek wasn't plowed for 3 days.
so was the hospital on diversion?
We were on diversion from the ER because the ambulance couldn't get in during that one part. We had to call and say, hey, you can't get in here right now, we need to divert during that time.
And how long was that time?
Oh gosh, that wasn't,
It wasn't very long, but Dr. Walls, we do divert during power outages only semi-stroke and trauma
No, I just
because of
wanted
the
to know.
CT.
No, I just wanted to know how long we were on diversion this time.
it was just a couple of hours this time, it was 6 hours. And that was just.
6 hours total,
It was
6 hours
It was 6
total
hours
for
for
the,
start time.
yes.
Do you know if there were any ambulances that were diverted?
No, because even though we were on divert, they came here anyway.
The first day, I can say the first day, the ambulance, the first day the weather was bad, they had a hard time getting in on the road, so they were really complaining about, hey, I can't even get in. And then the second day, we had 2 people that were visiting patients in the hospital that got stuck on the roads going out, and they were in their 80s. And that really broke my heart when they were out there, and it was actually 8 o'clock at night when one of those ladies
No,
got
I
stuck out
understand
there.
that, but my concern is if we divert them, where are they gonna go?
Yeah,
They're
that
gonna go to
weather,
Susanville?
you can't go anywhere else. Yeah.
Well, actually, it was easier to get to Susanville.
It was nice.
Yeah, it was easier to get to Susanville during those 2 times than it actually was.
Actually, the staff was making it back and forth there quite well.
Yeah.
It was here that there was the issue.
Exactly.
But I wanted Linda to talk about that so the board knew, what we had done and some of the measures we had.
Thank you.
Thank you for
It
that.
was a very good couple of days. We hope we don't have to practice again soon.
So as we keep talking about the weather, it caused some issues with our MRI, so we had to cancel the MRI a couple of times because of the snow-related issues. The Alliance for Workforce Development meeting that was to be held on the 15th got canceled, so I didn't get to go to that one. Let's see, the behavioral health meeting got changed. I probably know before I do that. The original day we weren't able to do because of weather. what we ended up doing on that one is meeting after the LAFCO meeting when, we went and presented our finances on February 11th to LAFCO. We had the CEOs there at the time, and we said, hey, so we, the three CEOs, we had some CFOs there, Karen was there, we went and talked to behavioral health, mental health over at Plymouth County. We went to them and we had a pretty good meeting with them.
And at some point you can tell me your topics.
I can. Also, we had a meeting actually at Sunset and Chester Fire regarding the ambulance coverage. Karen, that was your meeting, was that not?
It was Royce's meeting.
So we did have some conversation with them regarding ambulance services and coverage for our area.
Yeah, we're working on that, developing a plan that we can get patients down the hill in an appropriate time manner. So we should know something in the next couple of months of how things are going to handle between Lassen County and Plymouth County. That's our big issue. When Lassen County brings us patients, and then we have to transfer them out, now we have to use our Plymouth County services to get them down the hill.
And where's that disconnect?
Well, the disconnect is, a lot of times we get a lot of patients from Westwood, which overtaxes our peninsula and here in Chester department.
So Karen, I mentioned this to Linda, I did have a couple people from the community come to me to express concern about the availability of ambulance service.
Correct. And that is the one thing we're meeting on, and we're meeting with all of the districts to talk to them about that. We've had 2 meetings so far.
The ambulance in Westwood, although they sit a lot, it belongs to Westwood. So they can't leave the county without calling Banner. That's Westwood, so they can't come out of the county, although they want to help. So we're working on trying to see how they can help without making the fire chief in Westwood.
So is it a resource issue? We don't have enough money for the districts that we can?
It's not only, it's the fact that they have one ambulance there, that they don't want to take it out of service when they're bringing somebody down the hill for us.
Right.
So that's their issue. And staffing, if they could staff another ambulance, but then they have to staff 24/7 people.
You're talking about the Westwood ambulance?
Correct.
Right now. I was actually talking about our local ambulance.
There's 2. They have somebody out sick too right now on an injury, so they don't have backup. If our ambulance leaves the district, there's not a second crew to come in and cover.
Does Peninsula help you?
Yes.
They do.
And Elmore West, they all try and cover.
And actually, I have to say that SIMSA also helped us one day when we were in a dire need. They did come forward and transport a patient for us. I'm going to give them some kudos for that.
Well, doesn't Peninsula have 2 ambulances? Don't they have one at Hamilton Branch and one at Peninsula? So it seems like they could transport someone.
One of the biggest problems that we encounter is when you think about the ambulance services and where they're located and where their funds come from. There's been some issues in the community regarding, you pulled my ambulance out of service and took it down to Chico, and I had a problem in my ambulance was in Chico. And I couldn't get help, they had to come from over here to come pick me up because my ambulance was out of the area. So that's something that the girls are working on right now, the girls and boys.
Right.
On what do we do, how do we help them make that
coordinate
progress?
that?
We're the base station, so if we're taking the lead, how do you work through that? How do you work through it? This ambulance is taken out of service because we had to take somebody down to Chico. Who's now gonna cover that area even though it's not truly your area?
And that's what they do. They back us up when Chester goes down. Peninsula backs us up. So if Chester's down, then Peninsula's the only one. They don't want to take both of their ambulances out of service.
Yeah, but this isn't new, so what has changed?
Probably what Casey was saying, the person that's out on medical.
They have somebody out on medical right now, so they don't have there's not an additional medic. Usually the medic that runs all the transfers, he's out on medical. So there's not an extra person, an extra body to run for him right now.
And the other piece, when you asked what is new, at one of the LAFCO meetings, they talked about the lack of volunteers also. So that's the other piece, is the manpower itself, of who do they have to help.
If the volunteer requirements for volunteering is just as restrictive as if you were a paid person. So it takes
a lot to try to go and get those certifications and by yourself, and then go down to running and do the training and those types of volunteers.
So, and that's,
I don't think
and
they
that's-
have any volunteers that are paramedics anyway, you've got a lot of EMTs.
Right. So the good news is we're taking the lead on it and they're working on it, so, that's a good thing. We did, receive the letter from KBK that we are eligible, to apply for their grant. It's a $236,000 grant, so I talked with the department managers and we're gonna look at what is it that we wanna submit for. The submission date is May 1st. We will be submitting again for Collins, another grant through Collins Point, and we're just gonna keep submitting for grants there. Michael sent out to you earlier the skilled nursing facility assessment tool that Roseanne worked really hard at getting completed. It's a regulatory compliance, and it went through medical staff. We weren't able to get it on your board agenda in time so that you could actually locate it. And it's not that you need approval. We would like to get approval of it from you because you don't get to make really changes to it. But at least we've sent it to you. It, let you know about it now, so if we get surveyed between now and the next board meeting, we can say in true, without feeling bad about it, that we did present it to the board. So you will be seeing it back again next month, but we wanted to send it out ahead of time so you could look at it. And then again, if survey comes, we can say the board has looked at it and they're getting ready to give us responses back.
So is this prompted by the survey, or?
Yes, it's one of the new requirements, that we have, actually it's not even new, we needed to have it last year. It's a requirement, for the skilled nursing facility to do a specific skilled nursing facility assessment that's just skilled nursing, not hospital-wide. So in that, you can see there's the hazard responsibility study that we do. It's more of a document that's just specific to skilled nursing. Okay, so the provider recruitment update. Pat, I'm going to let you talk a little bit about it, but I'm going to steal your thunder because we got Dr. Taylor to sign, got him on the locum rule, and he's now ours, and he's talking about filling in more days than what he originally talked about. Yes, I can say that. I'm sorry.
Yes, so that actually brings us to almost a full ER staff of permanent ER positions. So we have a couple we still have for locums, but our costs should be going down now with Dr. Taylor as well. And I believe the backup is being worked on as well to relieve Dr. Ware and Dr. Walls of so much backup during the month. So they should hopefully not have more than a week each. And most important is Doctor's Day is this month, and we're going to have a celebration on March 29th. Doctor's Day is March 30th, which is a Saturday, so we're going to do it, we'll have a lunchtime celebration here on the 29th, and we'll send out information to you so that you can all join us. Stephen Hayden, our mid-level, is interested in becoming permanent. We've come into a few little clicks with the contract, but we're going to try and work through that. And then we're also bringing on our new dietitian from Willows, Erin Munjar, who it keeps trying to get up here, but the snow keeps delaying her. So. That's about all I have.
The other thing I want the board to be aware of, because at some point I will be coming to the board to let you know that what Piat's talking about, the hiccups or snags, is the buyout for the mid-level. Our new one, Teresa Nielsen, who's here, is talking about she really loves it here, she would like to stay. Both of the two mid-levels come to us through locums, not locum term. So when you work with buying out a locum that is a true locum, you're talking about a huge buyout fee. So I will be going to the medical staff to talk to the medical staff about what their opinions are, and then we need to talk to both folks to see what we can negotiate, and then I'll be coming back to the board when I find out all those big things, if it's gonna work or not to buy out those two levels.
Can you draw up a contract committing for so many years, and if they don't stay those years, they have to pay it back?
That's a piece of it that, I've got that at attorney already, what kind of contract can we hold them to? The other piece is to let them know that, you know, if we buy you out for this amount, we may not be able to pay a relocation or a sign-on bonus because we're buying you out. So there's a lot of moving pieces to this to see if they're willing to even negotiate that with me or not. We're working on it, but what I wanted the board to know is that, you know, those two mid-levels, one med staff still, we need to chat with med staff about their deal for them. And then can we meet them financially for what they want and what the buyout's gonna cost, and then I'll come to the board with this is what it's gonna cost us to get them. But I wanted you guys to know now before I have to come to you with. Unfortunately, we did, you forgot the one, and I forget his name, we interviewed a physician, gosh, it's been a little bit, but he turned us down. Then also I've had, Snow, which I had another physician that, I had from,
You're from See the Snow.
exactly, Merritt Hawkins, that they were talking to him about coming, and then it snowed, and he told them he didn't want to be here in the snow because he didn't think it snowed in California. Scott or Merritt Hawkins that has the graduate in 2020. Scott, so that would be, Jackson Coker. They have a new grad that's interested in us despite the snow. He graduates in 2020, so we've asked them to present a CV.
I haven't received it.
No, I just had, before I came to this meeting, and said, I don't have this yet, I need it. So we've been working really hard on trying to get recruitment for those positions. The snow is not helping us right now.
Snow could be a positive thing. I mean, a lot of people actually really like this.
Exactly, but that's how we got,
Frame it that way.
yes, so, I don't know, we'll get there. The update on SB 1152, the homeless patient discharge planning, Casey and Ashley sat in on the webinar. We gave they have the requirements. We're moving forward with that. They've also talked with Colusa County so that we are all on the same page to meet those new requirements for that Senate bill.
Are we coordinating any of this through the old ABC Center?
Well, that's part of what Casey and Ashley and myself also, when it comes to the community assessment, we're working towards SBR because we need to do this as a county so that we're all uniform in what we're doing for them.
Exactly.
There was just an article in the paper too, that the supervisors are working on something for the homeless as well. So I think we're all kind of on the same page, going toward the same thing.
And then the other piece is that both California Hospital Association and ACHD is looking at what can we do universally within the state. So that it's not just the counties that are doing the same thing, it's within the state as well, so we don't have the homeless moving to the areas that. Okay, so then the next piece is Sadie and I attended the Hospital Association Compliance seminar in Sacramento, and we brought back some things we implemented, some changes. So we're working through that. The IT assessment. So with the IT assessment, unfortunately, again with the snow, we've had to reschedule the orchard visit twice. So we're still looking at some March dates that will work. We're looking also for a reverse webinar so that the physicians can do the webinar and be here when that happens. We've had a couple of conference calls with CPSI, Dave Erickson, Doug Tonys, and Dr. Louds, so that we're moving forward with some better optimization and just giving them more of our concerns so that they hear it from us in a different environment. I brought Liz back in to help with the IT assessment that the board has asked me about. She's looking at it from the clinical informatics and the CPSI standpoint, I talked to Jim Hallenstein last night, and he recommended to me, somebody who can do the infrastructure piece to see how are we, with our infrastructure for our IT. So we're looking at this from two sides. We're looking at it from the actual infrastructure, wireless, the laptops, that piece. Help me, you guys, you IT folks back there.
The network, the bandwidth, how the circuits are optimized for which piece of data goes where at what priority. Had the wireless coverage, making sure that there's no dropping in each of the spots, and that's gonna take time where we're actually going and shadowing people for hours. We wanna go your whole shift. What is happening when you go here? What is happening when you go there? So we can actually log it and capture it and do analysis on that piece and where we need to put the dollars at to make sure that the physicians have, and, well, everybody has the right amount of coverage. And
so that's the infrastructure piece, and then we're also working towards making sure that we're using CPSI the best way. And when TK was talking about that optimization, one of the things that CPSI didn't do that we failed to ask them was, can you help us look at when we're using CPSI on the laptops, with the service pros, through the wireless? Is that an issue? So we're going to include that as well. John Helby is also going to be helping us. He's the CIO at Orchard. He's going to assist us any way he can assist us. Laos is helping us as well. So we're moving forward with that whole IT assessment, and that is one of the reasons why we pulled that contract this month that we presented to you, and why we're still full on hold with that EHR tool. Because we want to make sure that we do have the infrastructure here to support any new and added that we bring in. So that's what we've been doing with IT assessment. Legislative updates. Well, so our Governor Newsom is still really pushing that single payer source. What has happened right now is that there was no legislative authors. CNA proposed that single payer source. That wasn't ever an adequate proposal. None of the legislators decided to author that, and so that died, but Governor Newsom is still really advocating for a single payer source. We just don't know how. Still advocating for the health care for children, advocating for behavioral health and mental health, the homeless with the housing, and the drug, prescription drug issues. Still don't have anything new yet, other than those are just hot topics. And I'll keep you posted as we find out more. Okay, vaccines for juveniles. That's been an issue. It's been an issue because of up in Seattle with the measles epidemic. One of the things that I wanted this board to be aware of is we have had a couple of juveniles come in and say they wanted to be vaccinated without parental consent. Right now, we cannot do that. So we refer them to the health department, and let the health department deal with that legal quagmire. We cannot give vaccinations to juveniles without the parental consent right now. That's just the law. We can't do it. So if you hear anything out in the community that there's some, because we do have a strong group of juveniles out there who don't want measles and they want to be vaccinated because their parents haven't vaccinated them, that's the stance that we have to take right now.
That's an interesting piece, because demonstration of sufficient maturity, juveniles can receive mental health treatment,
Yes.
Absent their parents' approval, but there has to be a demonstration of sufficient maturity.
Yes, and I'm not even going to get into the
Well, I would get, if you're
other side.
looking for legislative relief, that's the avenue.
Yes, so,
you're saying it's California state law that we can't do that?
well, right now, when we look at the consent manual that we get from California Hospital Association, we cannot give them vaccines without parental consent.
So how are we referring them, I guess, to Canada? We don't have county public health here in Canada.
No, we don't. And so what we tell these juveniles, we can't give this to you. We're really sorry, but we cannot give you this vaccine. Maybe discussing with public health would be helpful. probably not, but I don't want these kids to just think this is an end all, you know, we said no, so therefore no, I don't want to slouch them, and I'm going to drain them, or we're actually having to refer them to public health because they can give them better answers for us. Now, one of the pieces that is in the legal side right now is if we have a provider who knows the family and knows the child and has to use that, the child can, and we're not talking emancipated minors because parents have to hold them. Right now, legal is talking about what if the provider says, I'm going to vaccinate that child. I know the family, I know this child and we need to do that. That's a whole different legal piece that is going down that road too. So this is just, it's a gray area for everybody. And we don't know what to term when we do have these juveniles who want to be vaccinated.
Now, when you say juveniles, what age group are you talking about?
18 and under.
18 and under. If they're in school, they have to be current on immunizations to go to school.
They're homeschooling now.
Oh, okay.
So I wanted the board to know that, you know, this is a big dilemma for everybody right now, and that we're working through it, and that if you hear anything out in the community, listen forward.
Have we talked to county public health about some sort of coordination?
Yes, Tina is just as much at odds as we are about what can we can give them information, we can give that information so that they can take to their parents and try to talk their parents into it. That's,
They're not providing any either, is what you're
no,
saying.
they can't either.
There's legislative.
And I talked to you about the behavioral health meeting. The last piece I wanted to talk to, oh no, I didn't talk to you about the Northern Region CEO meeting. So we put together the CEOs and interviewed, and I talked to you a little bit about the CEOs in the meeting. The next meeting is April 19th here at Seneca, and at that meeting we're asking Plymouth District to tell us how, because they're designated the rural center of excellence, they've got residents that they're seeing through UC Davis, and we want to jump on that wagon and try to do that too. One of the things that Dr. Keppel said is how they got that is because they have OB. And that's all I have for you right now. I'm sorry it was really long, but I wanted to get you updated.
That's fine. Important to be thorough. Okay, then we'll move on with departmental issues. Ashley and Casey.
So care coordination is, like I said, working on Prime. The submission date for DY14 is March 31st, so we've been working on that this month. Care coordination also just purchased, we got approved quiet packs to improve our HCAPs and the quietness of our facilities while our patients try to sleep. So every patient will get a welcome kit now. I told you that we are putting HCAP surveys in each discharge packet to just make our patients aware of what to expect and what to fill out. And that's all I have.
We are working on the opiate grant with Plymouth County. It's their grant, and we're kind of just helpers with them. We did our risk assessment. They had their first meeting. We updated our need assessment to include the schools because there is no more DARE. We just had a big vaping meeting that Jim went to, so we reached out to Plymouth Unified School District, met with Gina. They will take any help they can get from us if we can go and help, you know. So we put the school in our need assessment to try and start at the school district level. And then the CNA program, we are working with Plymouth Unified School District with Gina Pixler and with FRC to all of us come together and collaborate. FRC has a program, but they don't have instructors or a facility to do clinicals at, and we have those things. So when's our next meeting? In a month? Next week. We have another meeting with them. Ashley and I had to apply at FRC. So we're working out all the kinks to hopefully be able to get some CNAs up here and allow the high school students to do the program their senior year. So we're looking at starting in the fall. It will be a class for the high school students and adult learners that will be held at Chester High School.
Good.
And that's that piece of the Grow Your Own program we're working on as well.
Karen?
Okay, I just wanted to tack on to what Linda said about how everybody acted last week during this time of bad weather. I was so impressed with the people that walked in But we were in communication with most of the managers at 4:30 and 5 o'clock in the morning, but I also wanted to give a shout out to those people that had to stay in place until staff got in, and we had quite a few that stayed till 9 or 9:30 when they worked all night long and were supposed to get off at 7. So we really want to make sure that we also thank them. I can tell you, coming from a place that has hurricanes quite frequently, when I worked at the hospitals back home, you're given a time to come in when the hurricane comes. You have a time before the hurricane or a time after the hurricane. If you don't show up for either one of those times, you get fired. There's no ifs, ands, or buts about it. These people came in on their own. Most of them walked in actually that second morning, most of them walked in, and I was just thoroughly impressed with that. They really deserve, and Miss McCurdy, wherever she is right here, was here all night long, so we were able to be in communication to find out if we could even get in, if the doors were, plugged up with snow. So thank you, Linda, for all that you did.
Never leave your doors plugged with snow.
So it was quite, I mean, we kind of needed something like that, let us know that this snow does come. We know we have this snow, but it was kind of difficult for some of the people to get in, and they all pushed through and showed up, and I was just so proud of them. On the other side, we have hired 3 RNs, and I could do the happy dance right now. One of them was what Steve had said about the traveler. She worked for us for 13 weeks and then decided to stay on, so we were glad to have her. Then we hired another RN who's a new grad, so it's going to take us she's quite smart, so it's going to probably take us less than 6 months to get her up and running on the floor on her own. And then we hired a very experienced per diem RN, so we're happy to have her. So things are looking up for us in the RN department. We can keep our fingers crossed that 2 more is what we need, and then we'll be fully staffed.
We won't say that.
Is that the bad word?
That's the Q word. Yes.
I don't have anything new exciting to report, so we'll say status quo is good.
Thank you. Jacob?
From the informatics side, both Sarah and Candace have completed their continuing education for physician administrators through the Evident Thrive UX EHR. So they are once again recertified to help the physicians in any way they need, especially with some of the new ER physicians that are coming through. We're also bringing back the RN training and nursing training so that with all these new hires that we are getting, they will come back to us upstairs and they'll get about a 4-hour just one-on-one session on how to get through, how to get into Evident, how to get through it, how to document correctly, and hopefully we'll be successful in that again. From an IT standpoint, we've finished up most of the upgrades that we have left to do, short of the servers. We're putting the finishing touches on the voice over IP phone system. Once again, the weather has postponed that a couple of weeks due to not being able to get people here for hands-on training before we go live with that. Right now we're scheduled for the middle weekend of March to get all that rolled over. Once I have all of that solid, we'll put something out on our social media sites and such to let people know that when they call in, they're going to hear a different voice. It's going to be a different recording. There's going to be more options. And what's really going to change is when you call into the walk-in clinic, that one's going to go to a auto answer also. But it'll be very simple. Press 1 will get you directly to a receptionist, or press 0 will get you directly to a receptionist. As most people are pre-programmed to that, they pick up the phone. As soon as it starts talking, they just press 1. And if they don't get what they want, they press 0. So we put that in place already to help alleviate some of that. And that's a project we've been working on for quite some time. So it's going to be nice to have that finished up.
I have 2 questions for you. One is, any truth to the optimistic rumor that TK is coming back?
I have not spoken to TK, so I cannot answer to that.
So all we can say is she called me, she said she wants to come back, we've seen no note yet. that I can't.
That's fine, that's fine. The rumors in warehouse stuff.
Oh, definitely.
The other thing is there any way that we can have the phone system tied in with an automatic call to tell the patients that they have an appointment?
A reminder of their appointment.
I will look into that for you.
Because someone told me that with this system, we might be able to do that.
I don't see why not, but I don't want to give you a definite answer until I've done the research.
Okay. All right, thank you.
Call back.
Let's see, I think Jacob is probably enough. Lindsay?
So, I have a chamber meeting, we have a chamber meeting next Wednesday, so I'll have a chamber update at the next board meeting. The biggest piece that I've been working on, along with Jim and Linda, we partnered with KTV and Channel 4 in Reno to do some geofencing display ads for recruitment. And recruiting the professional and certified level employees, our RNs, our LVNs, lab techs, radiology techs, etc. I just got the final proof today to approve to go live. What it is we pick 2 locations where we want to target for recruiting. We give them the address, and within a half-mile radius with the longitude and latitude, they will serve these ads within that circle. So, nurses sitting in their break room, playing a game on a website, on a tablet, their phone, on a desktop, our ad will be served saying there's like 3 pictures, there's a lake, there's some snow.
No snow.
Vacation kind of messaging, in hopes that we can catch without the big cost of newspaper ads. We have the ability to change our locations, to move them. We also have the ability, if we know of a big job fair happening, we can give them the address of the convention center, say it's in Sacramento, and they can that weekend serve the half-mile radius of the convention center with our ad that, okay, here's a hospital recruiting and hiring. If we're starting with the certified and professional level, my hope is that it turns into brand recognition as we start to move forward with new build and exciting stuff in the future, that areas further than just Chico and here and Reading know about us, and they see us, we're kind of just reaching our arms out. Is this a clickable ad? Yep, it serves right back to our landing page of the job openings, so they can read that and apply. So I'll be monitoring web visits, page visits, to see how it increases. If we watch one area for 3 months and we're just like, oh, that's not doing it, we just give them a new location and then they go put our ad somewhere else. So, yeah, pretty exciting. Do you want to do a public service announcement or a town talk? Yes, I was trying to remember that. So the town talk, the chamber is hosting a town talk working with St. Andrew's Academy on Friday. This coming Friday, there's Walk and Nupa will be there. It's just kind of like their regular, not a chamber mixer, but where they set up in different areas and we have tables with different groups that are promoting what they're doing. And this one is kind of piggybacking on the history of St. Andrew's because it's their, I forget what number it is. 100 years.
20th.
Yeah.
100 for Collins, 20th for Andrews.
Okay. So that's Friday. And they moved the location. Oh, I didn't get that email. Let me look it up really fast, sorry. You can keep talking. That's all. So, sorry. She said they moved it to the CPUD fire station building because there were too many people. Oh, no, sorry, wrong one. That's not bad. That's not bad, just kidding. Okay, still St. Andrews. Just kidding, still St. Andrews. Friday night, Walk and Nupa will be there serving their local beer. And then, chili, yeah. So, yeah, that's all.
Thank you.
Questions? No?
Every church should have their own branded beer.
Yeah. Right?
Jim?
Well, you've got your list of additions and deletions. We had a pretty busy month. We got a respiratory therapist per diem, a full-time medical receptionist. Karen told you about the staff RN per diem and a student. We also have another medical receptionist, and an LVN on a part-time basis. We also have one of our community members, or young lady going to school, reached out to Dana regarding getting some time observing in the hospital and probably the clinic, so that she can move on. She has to kind of get these hours in so she can move on to her next step in her education. And so we're bringing her on next week. I'm not sure how much time she's going to be able to commit. It sounds like 1 or 2 days a week. She has so many hours she has to fulfill. So we're going to try and work with her, and we've got that all set up.
The first year project?
Pardon me?
The first year project, or is that something?
No, it's basically, well, maybe you understand it more. It's she's going to move on to eventually an RN program. And so in order to get to the preliminary, she has to get this kind of time in. It's like a pre-med.
hours in the hospital before they'll admit her into the.
So it's just another piece of the Grow Your Own program that Jim's been working on, so that we make sure that the community is aware that we're doing everything we can to help them further their education, but while we're doing that, hopefully, we buy some of their support to come back to the community.
And we have a conditional offer, actually she started yesterday, to an admissions HIM tech, and we have lost one of our radiologists to retirement, and we had an HIM tech lead who resigned.
So that radiology tech that retired was the one that we was out on the medical leave when we had to hire a locum for. So now that we've got the official retire, we can now advertise for that position. We could not advertise for that position before, even though we had a pretty strong idea that she wasn't going to come back. Now we can advertise and get that position filled with one of our own. We will kind of handcuff until we got the actual retainer.
And I wanted to talk a little bit about the meeting that I went to in Casey and Ashley's stead. They for the vaping. I just kind of was filling in, and I was shocked at what they presented. The information they presented: kids from 9 and 10 years old in school vaping. And vaping sounds great. Vaping is flavored. It's nicotine. They had a little thing that looks like a USB port that they flip up and they're done. And that little thing is about a whole pack of cigarettes. And I was just shocked. And so what they're going with, the county health department, they came down to about 5 folks who are going to sit and make a little plan strategically what their goal is, what we want to do. But I pass that on to Ashley and Casey. And our goal, of course, is education. Education of the kids, education of the parents. Because nobody really thinks, oh, it's flavored, it tastes great, has raspberry, have cherry. And they think it's okay. They think they can't hurt them, and it's nicotine going into their system. They don't really understand that. There's no laws against it. Well, there's laws against it below 18, but the nicotine folks are marketed to these kids.
Jelly bean flavored and things like that.
Yeah, insane. I was a little bit taken aback, to be honest with you. So.
Dr. Walsh, we left Rosanna for skills.
So, do you have anything to say, Roseanne?
So your skills are seen?
Do I have anything to say?
I did not want to leave it out.
We're writing lots of policies, so be ready for next month. Be ready. The whole book is getting rewritten.
About 50 pages of yours.
You will have 50 pages of mine, sir.
Linda, if I could say one more thing. One thing we forgot to say, we hired a new employee, and I guess Jim maybe can answer for who it was. She was due to start work that first day that we had the bad weather, or the second day we had the bad weather, I can't remember for sure, but she came in and she was very tearful. And when we stopped to ask her what was going on, she showed us a picture. She was here in a motorhome, and a tree fell on her motorhome. She still showed up for work and on time.
She's a campfire survivor.
Yeah, and she had already survived the fire down in Paradise, and she showed a picture that the tree was 4 inches from her head in her bed. And that lady still showed up. I'm like, I want her over there at the hospital with me. But we were heartbroken for her. We were heartbroken for her when she came in. And she not only had her, but she had her daughter in the motorhome, her 2 grandchildren in the motorhome, and 2 or 3 dogs? 3 dogs. 3 dogs.
Yeah.
Do we have hired her and her daughter?
And the dogs, if we could get them. Dogs. Okay.
Thank you.
We'll have a closed session.
I'm sorry, how are you, Teresa?
You want to go over the agenda items from
I have them all written down.
We're going to be sending out the request for the meeting dates for the board of talking about. We're going to, you already set your meeting date, you outlined. IT server will be back on, you'll have a report with a request for some IT equipment.
the CDO evaluation.
Yes, the CDO eval.
And when that evaluation is supposed to be done.
Yeah, I think that's it.
Okay, and we will adjourn for a closed session.
Okay, the regular meeting is now open. We had a closed session and we discussed the quality review process and union negotiations. No decisions were made. The next meeting, we've established that on March 25th at 9 a.m. we will have a special meeting, and on March 28th we will have the regular board meeting at 3 p.m. I think the meeting is now adjourned.